Today we're going to review the complete blood count, or CBC. This is one of the most commonly ordered lab tests in medicine, and it provides us with critical information about the patient's overall health and disease state. We'll break down the main components, including hematocrit, hemoglobin, platelet count, red blood cell count, and the red blood cell indices. Understanding these values not only helps us detect conditions like anemia, bleeding, or clotting disorders, but also provides clues about more systemic diseases. By the end of this session, you should be able to interpret these results with confidence. Starting with hematocrit, it's one of the fastest ways to get an idea of red blood cell levels. It gives us an indirect measurement of both the number and the size of red blood cells. The test itself is very quick, essentially a rapid snapshot of how concentrated the red blood cells are within the total blood volume. Because of this, hematocrit is often used alongside other values in the CBC to evaluate a patient's oxygen carrying capacity and fluid balance. It is ultimately the percentage of blood volume that's made up by red blood cells. After centrifugation, the height of the packed red cell column is compared to the total height of the blood column and multiplied by 100%. Clinically, we'll often use the rule of threes. In a normal situation, the hematocrit is roughly 3 times the hemoglobin concentration. This relationship holds true when red blood cells are of normal size and have normal hemoglobin content, making it a useful quick check when reviewing labs. Normal hematocrit values vary by sex, age, and physiologic state. For adults assigned male at birth, the normal range is 42 to 52%. For adults assigned female at birth, it's slightly lower at 37 to 47%. Pregnant individuals often run lower, with anything above 33% considered acceptable due to hemodilution. Elderly patients may also have slightly decreased values, and pediatric ranges are more variable, with newborns having much higher hematocrits, up to 64%, and younger children running lower before stabilizing in adolescence. When hematocrit levels fall below 21%, this is critically low and represents a significant risk for hypoxia, organ dysfunction, and even cardiovascular collapse. On the other end, if hematocrit rises above 65%, blood becomes dangerously viscous, which increases the risk of clotting, stroke, and impaired circulation. These are thresholds that demand immediate clinical attention. Hematocrit is included in the standard CBC, so it's routinely measured for many patients, but specifically we look at it when evaluating anemia, when assessing ongoing bleeding, or when we need to follow a patient's status over time. For example, serially checking hematocrit levels in someone with GI bleeding. It's simple but a powerful test for monitoring red blood cell balance. Collecting hematocrit is straightforward, no fasting required, and the sample is drawn into a lavender top tube which contains EDTA as an anticoagulant. Because it's part of the CBC, the same sample provides data for hemoglobin, RBC counts, and other indices. The key is proper handling of the sample to avoid clotting or error. Several factors can interfere with hematocrit readings. Abnormally large red blood cells take up more volume and can artificially raise hematocrit, while very high white blood cell counts can lower the apparent value and make it look like anemia. Hydration status is another major variable, as hemodilution from pregnancy or IV fluids lowers hematocrit, while rehydration concentrates the blood and raises it. Living at high altitude increases hematocrit as a normal physiologic adaptation. Medications, such as ones listed on this slide, can also alter results. Importantly, acute hemorrhage may not show an immediate hematocrit change, since both plasma and red cells are lost at once. When hematocrit's increased, we can see erythrocytosis, as this can occur in both disease states and normal physiologic responses. For example, congenital heart disease and chronic lung diseases like COPD cause chronic hypoxia, which stimulates the bone marrow to make more red blood cells. Polycythemia vera is a bone marrow disorder where red blood cells are produced inappropriately, leading to very high hematocrit. Dehydration, such as from burns or severe diarrhea, can also elevate hematocrit, because the plasma volume decreases while the absolute number of red blood cells stays the same. Recognizing these contexts is critical in interpreting a high hematocrit result. When hematocrit is decreased, the most common cause is anemia, a reduction in the number of red blood cells or the hemoglobin content within them. Hemoglobinopathies, such as sickle cell disease or thalassemia, can also lower hematocrit because of the abnormal hemoglobin either shortens the RBC lifespan or reduces production. Cirrhosis contributes to decreased hematocrit through chronic fluid overload and impaired bone marrow function. Hemolytic anemias also play a role here. Red blood cells become destroyed faster than they can be replaced. Finally, in cases of acute hemorrhage, hematocrit may fall after some time as plasma volume normalizes, though initially it may appear stable. Other causes of low hematocrit include dietary deficiencies such as lack of iron, B12, or folate, all of which are necessary for healthy red cell production. Mechanical destruction of red cells can also occur with prosthetic heart valves, which shear and damage cells as they circulate. Kidney disease is another major contributor because the kidneys produce erythropoietin, EPO. Any impairment can reduce red blood cell production. Lastly, pregnancy is a normal physiologic state of hemodilution where increased plasma volume dilutes the red blood cell concentration, lowering hematocrit even though overall blood volume is increased. We also see low hematocrit in chronic inflammatory and autoimmune conditions, such as rheumatoid arthritis or other collagen vascular diseases. These states suppress bone marrow activity and shorten red blood cell survival. Bone marrow failure itself, whether from aplastic anemia, toxins, or medications, also decreases hematocrit. Hematologic cancers like lymphoma, multiple myeloma, leukemia, and Hodgkin's disease directly affect marrow function by crowding out normal cell lines. The end result is insufficient red blood cell production and persistently low hematocrit values. This slide kind of transitions us into our next section. It's one of my favorite graphics from Osmosis, which is a fantastic resource and tool to learn about lab diagnostics and medicine in general.